Hello, I'm Lydia Shapiro, an Associate Professor of Medicine at Stanford University School of Medicine. Welcome to Medscape Oncology Insights. Joining me today is Ethan Bosch, the Director of the Cancer Outcomes Research Program and a Professor of Medicine and Public Health at the University of North Carolina in Chapel Hill and the Lineberger Comprehensive Cancer Center. Ethan, thank you for joining me and welcome to the program.
Thanks very much for the invitation, Lydia.
It's my pleasure. I'd love to chat with you about PROs, and your name is almost synonymous with PROs. PROs, as I understand, were first thought of as a mechanism for bringing the patient's voice into the conversation and into research. Tell me a little bit about how they evolved.
Sure. So in general, patient-reported outcomes were previously referred to really as quality of life, a field that you and I both have been involved with over the years. And many of the questionnaires or approaches for assessing quality of life, or really patient symptoms, were developed for clinical trials, for research, in order to understand, for example, if a treatment in metastatic prostate cancer was improving pain related to castration-resistant metastatic disease. But over time, as these tools evolved, it occurred to some that these might actually help in routine management of symptoms as well.
And how do we implement these patient-reported outcome instruments into, say, routine follow-up of a patient in the clinic?
It's a great question. There are a number of different ways that I think are appropriate to various contexts. But in general, in medical oncology or in radiation oncology settings, electronic tools have been used to send questionnaires to patients, say via a text message prompt or an email, to go online to a very brief questionnaire between visits to let the practice know about key symptoms, right? For example, their pain or their nausea or their constipation, the kinds of symptoms often that are actionable to us as oncologists, right, or as providers, but also those things that can really get people into trouble. An alternative approach is the in-clinic approach, and that's also quite commonly used where, say, iPads or tablet computers would be available in the waiting room, and the front desk person might bring them to a patient to fill them out, and then this information is available to the care team at the visit.
One of the things I wanted to ask you about is that fact that it seems to me that this is an opportunity also to find out what quality of life is like between visits. Because we often ask patients on the day they're coming to see us perhaps for treatment when most of the toxicity perhaps has resolved of the prior treatment. But do you use these instruments, or do clinicians in practice use them maybe on day 8, on day 15, so that they actually can see what the quality of life is during those times?
Yeah. Well, the first thing I'd say is that one of the reasons why there's been so much interest in using this electronic symptom monitoring approach in our patients during treatment is that patients receiving cancer therapy are highly symptomatic. The vast majority of people have symptoms, and about 2/3 of them have symptoms that really meaningfully interfere with their lives. And these symptoms can get people into trouble, right? People get dehydrated, they have pain crises, they have dyspnea crises that lead them to the ER. And on top of that, there was a lot of research demonstrating that we as providers miss more than half of our patients' symptoms. Even when we talk about symptoms in the office for various reasons, this information doesn't rise to the top. And I can say, myself as an oncologist, it's not that infrequent that I'll have a patient come back in and their daughter will say, Dad was in bed for 2 weeks after chemotherapy. And I say, Mr. Jones, why didn't you call me? And, he'll say, I didn't want to bother you, doc, or sometimes people will say, well, I thought that was normal, right? I thought that was just part of the thing. And there are all kinds of barriers. People don't want to let their doctors down. They don't want to admit to having troubles. There are all kinds of dynamics that lead to us really not understanding what's happening with our patients. And so for this reason, there's been a swelling of interest to monitor people between visits, as you say, using these electronic approaches. During active therapy, right, really with immunotherapy or a cytotoxic or a targeted therapy, in general, people are asked about every week to report. There are some approaches where it's actually timed to the chemotherapy, so within a window after receiving treatment. But because there's so much variability in how cycles work, and because that usually requires tethering to an EHR, the every week ongoing approach seems to be pretty effective. And the way this works is that patients may get a prompt to self-report, and if they report something that is severe or worsening, it will send a message, usually to a nurse who manages symptoms, and then that nurse can react to that information.
So it seems that there are a lot of steps that need to be in place for this to work. A mechanism for pushing these out, a portal for the patient then perhaps to send the message back, a way for it to be incorporated into a dashboard or workflow that then triggers a timely response by a clinician. I imagine there may be some problems or issues for many practices to implement this complex system. Can you tell us a little bit about what the state of the art is in implementing this in the community?
Absolutely. So you're right. Like any change that we make in practice, any of these new value-based care approaches to trying to improve the quality of the care that we're delivering and the patient experience, there's effort. And in the case of patient-reported outcomes, it involves a technology lift and a modification of workflow. And of course, education of providers and right, a little bit of culture change. But as providers, right, our practices are accustomed to this kind of thing. We do make changes all the time. Sometimes they're more painful than others. For example, electronic medical record implementation, and sometimes they're easier. I think in this case, this is something that is so in keeping with the mission of our practices to improve the lives and the experiences of our patients. In addition, we know that these interventions reduce emergency room visits and hospitalization. They lengthen the time tolerating chemotherapy. There are a lot of benefits. So I think it's worth it in this case. But you are correct. It will require having a technology solution. That would either mean working with a company or a vendor that provides PROs. There are many of them out there. Or doing this through the EMR. Many of the EHR systems do include a PRO functionality. But it also means figuring out who's going to get these alerts, who's going to get these reports, who's going to discuss this with the patient, who's going to react. And that means generally piggybacking on top of the way that we already manage symptoms. Usually that might be related to the telephone triage approach that, oftentimes it's nurses who oversee that, but it varies from practice to practice. So a little bit of thoughtfulness is required, but it's very feasible.
What do patients and family informal caregivers say about this?
Yeah, so it's interesting. When I started becoming involved in this work, it was not uncommon that particularly oncologists or clinical trialists would say, this will never work because patients are too sick or they're too well or they're not interested. There's a reason that we as oncologists take on this role of trying to figure out what the symptoms are without asking the patients directly. It's because it's not going to work. It turns out, in fact, that not only is it highly feasible with the vast majority of patients being willing and able to do this, but there's tremendous enthusiasm. There have been many studies now doing interviews with patients and surveys of patients using these approaches, and it turns out that most patients feel more engaged in their care, they feel more cared about, they feel like they're a part of the process of delivery, they feel listened to by their team, they feel that their conversations are improved with their doctors and nurses. So there's generally a very high level of enthusiasm. It's not universal, of course, like anything, but the majority of people really like this.
And I imagine it can also help the family caregivers because they can perhaps prompt the patient to be more forthcoming in reporting symptoms, right? So it seems one of the intended or unintended consequences is that it improves communication. Do you think it is also perhaps provides a segue for talking to patients when you actually see them in the office or in clinics about their goals and what's important to them?
I think so. What has been found is that the substance or the quality of conversations with patients are much more in line with the things that patients care about and that are affecting them. And so um, there's a much more efficient communication with patients because those things that are on the patient's mind are then foremost, and you can start there. What's been found is that there's no increase in the duration of clinic visits, but the content of the clinic visit is much more meaningful to patients. And you're right. These systems don't only collect information about symptoms. They now are starting to collect information about financial toxicity, about transportation problems, about barriers to access. So all the sorts of things that we all know are challenges for our patients that may interfere with our ability to be effective as providers can be captured. And so I think that a secondary result of this is that it's an impetus to discuss these important areas with our patients.
So for a community oncologist or practice, for instance, how do they know which instruments to choose to insert into their systems?
Yeah, it's a great question. Many of the either companies that are doing this or the packages will have generally a set of items. Most of the systems doing this have a core set of symptoms that are collected. They're the most common or troublesome symptoms. And many of them will have some of these other areas too. For example, patient-reported ECOG performance status, dehydration, falls. There are also packages in the post-operative setting. We haven't really talked about that, but there are questions that ask about bleeding or wound problems or fever. So depending on the context, generally there's some expertise that comes along with it. That said, this field is still evolving and emerging. I think that there is no true standard yet, and so I think there will still be some variability.
And where do you see this going? I think we talk about, how perhaps new wearables or artificial intelligence may help us capture more data from patients. How do you think that could impact the collection of data and reporting of data through these PROs?
Yeah, it's a great question. I mean, the first thing I'd say is that I think there are various vehicles by which these systems will start to become more commonly used. I think in the setting of alternative payment models or innovative ways of delivering care, value-based care, these approaches will become, more widely used and integrated with other interventions like navigation, or care coordination. As this field evolves, I think you're absolutely right. I think that there are new technologies that will bring us to the version 2 and 3 and 4 of this approach. The way the field has developed is really rudimentary. Static questions that are the same question is asked every single time of the patient, and it might be uninteresting after a while. We know it is. And so some of the newer approaches are using chatbots to have a more conversational or iterative approach. There's a beginning of some intelligence to start to analyze at the individual patient level which are the most problematic issues, to direct what the questions are. There's some intelligence around alerting to use predictive analytics to figure out who are the patients who are really at risk of winding up in the emergency room or missing a dose of chemotherapy because of the constellation of different variables, right? Certain disease, certain treatments, certain cluster of symptoms, certain economic status or insurance status that put them at very high risk that can then maybe flag a navigator or a care coordinator to reach out proactively. And then the wearables, I think, which I know you and I are both interested in, as a way to passively collect information, as really a better way of collecting performance status so that we really know how active our patients are.
So it's almost as if you can profile the patient as well. and then from that, try to stay one step ahead of the problems by anticipating where they can run into trouble and pushing out perhaps some questions, and so hopefully avoid some of the unnecessary suffering and also costs associated with having treatment for cancer.
Absolutely. I totally agree with that. And if you think about it, this is something that we all do intuitively in our minds all the time, right? We look at a particular patient, we think, oh, you know what? This person's not going to make it, right? Or we better give this person a call next week to see how they're doing. So we are risk stratifying people by weighing variables all the time. This is a way of improving the precision of something that we really already do, as providers. We manage symptoms already. We try to meet the needs of our patients. We try to communicate well with our patients. We try to tailor what we do to the needs of an individual person. And this is really just a way of being more scientific and systematic about it.
Well, thank you, Ethan. This has been such an interesting conversation. Thank you very much for joining us.
Thank you, Lydia. It was a pleasure.
And thank you for joining us. This is Lydia Shapira for Medscape.